My journey that I'm going to be using to highlight these issues has been of a doctor who trained in one of the best medical schools in India, and then I served as a teacher doctor there for about 10 years before I decided to move to the poorest part of India, which is central India, where, because I was also interested not only how to diagnose and treat illnesses, but also how to understand the whys and hows of ill health. So I relocated to this part of India, and I must, even if it sounds immodest, I would say that what actually hit me was that when you see so much of injustice around, you cannot but respond to this. And I also knew that Martin Luther King had said once before that there are all types of injustice are bad. But I maybe as a physician, but I felt that not getting healthcare when one wants to get healthcare is the most unjust of the injustice that one can get. Imagine if someone has a fracture and one is not able to afford to go to a hospital to get a fracture set, or if my child gets a pneumonia and is short of breath, and I understand that if I go to the hospital then it might cost me money that I cannot afford, then that is soul breaking and heartbreaking, and thus that is probably the most unjust thing of all. And thus, in a world where we know that in the last 2 years also, actually inequality has increased. Some people have become extremely rich. We have read from newspapers and learned from the media that someone like Jeff Bezos, who owns the Amazon, has multiplied his assets by several times, and so has happened in India. The two richest people have made so much of money that even the government of India has not spent that money in the entire 2 years. The entire government has not spent that much money that those people have increased in amounts. And I am also a great fan of this German doctor who turned to be a parliamentarian later, that if illness, if deprivation, if marginalization is causing illnesses, then physicians or people who are working in health become the natural attorneys of the poor, natural advocates of the poor. So I relocated from a part of India which was Delhi, where I grew up in this bit, and moved to this central Indian state, where the problem is of inaccessibility. That there are roads, there are villages and entire areas that are cut off from the main cities because of rain or water in the winter, in the rainy season, and often vehicles have to be pulled by animal power to transport them across, because at least like here the buffaloes are pulling a jeep of our hospital, and so this bit of central India is forested, also has a lot of malaria, has a lot of malnutrition, and a problem of civil strife, which people like to call it as 4 M's: malaria, Maoism, mosquitoes, and malnutrition, etc. But so this area where if you look at adult people, yesterday day before when I was at Tembisa, I was realizing the average weight of a woman in my area is 41 kilos, median weight. That means 49% of women have even weights lower than 41 kilos, and men have weights of only 49 kilos. And even in that, there is so much of inequality among the weights that the people who are called the indigenous communities in our area have such low what we call body mass index compared to people who don't belong to the general class or the general caste in India. And I'm sure this sort of racial differentiation in our nutrition levels is there even in Africa, in South Africa, where so the structure that we created was, the hospital that we created and the health program catered to 3,000 villages, a population of almost 1.5 million population, where we ran a hospital which was extremely busy. And I'm just showing some pictures of a ward that are always full, simple, where we also provided drugs to everyone, and drugs at prices that we could afford to provide. And I saw that, you know, in South Africa the pharmacies charge frightfully more than what the cost at which the drugs are produced. And we also ran a laboratory where we could do complex tests as well as, you know, very simple tests with only pieces of equipment. A microscope is there, a colorimeter is there, and a centrifuge. And also, you know, because the main part of healthcare is the people who provide healthcare. It's not the machines, or it's not places. So even like, you know, these are my health workers, community health workers. This woman is a senior health worker who's training another health worker using a stethoscope. You must have seen a doctor using a stethoscope with one pair of ears and one pair of, you know, the chest piece. But this stethoscope that we created could have two lines, and one person could teach the other how to do it. And I'm sure health workers here would be able to use it if we start providing them, provided we have the intention to, you know, sort of allow people to use it. So, you know, this question would strike you when you are working in a deprived area. Why are a large number of people among us unhealthy, particularly people who are living in deprivation? And the simple reason is that, you know, we have created two sort of healthcare systems, one for the poor and one for the people who are not poor. Until or unless this is one statement I would like to start with, to say, unless you have a common health system for everyone, you are going to have this unequal distribution of healthcare, of illnesses, not healthcare. So this is a problem that happens in almost all unequal countries. And I must count, there are 4 unequal countries that I think in the world which have large populations. My country is probably the most unequal and most unjust of all, India. There is another country like Brazil, which is in another continent, Latin America. There's another country called Indonesia, which is also large population but very unequal. But I would say South Africa joins these four countries to make it one of the areas that, you know, we are very unequal and very unjust in a sense, in that, because inequality is not due to any other reason except due to injustice, is what I would like to say clearly. So, and that happens because, why don't we have this common health system? Because we don't have equity. You know, the fact that we all are common animals, common human beings, that we are common, you know, people with same needs, same desires. Equity is not an underpinning in our health, in our intervention, and that leads to this problem. And that is the reason poor people get poor health systems. If you make a health system only for the poor, it will become poor. It has to be a common health system where everyone, irrespective of our ability to pay or earn, have to be provided the same quality and quantity of care, is what I would say. And, you know, I would say from my example in Chhattisgarh, in central India, you know, all illnesses can cause some deaths. But in the case of 2 major examples of diseases that kill the poor more, at least in my country, and I'm sure these also happen in some parts of Africa, if not South Africa, that we say that malaria may happen in cities also, malaria may happen in villages also, malaria may happen in a rich place, in a poor place. But malaria deaths start where political power, our power to negotiate with the system, ends. Or snake bites also. Snakes will bite where there are human beings and where there are rats. But snake bite deaths in India happen where poor people don't have political power. So, and you know, this manifestation of injustice of health systems and unequal health systems manifests through different methods. One is, there is no study to show what proportion of illnesses happen among the rich and among the poor. Yesterday, in Bela, someone said, "Oh, rich and poor all have common illnesses." I think that's an incorrect thing. There is actually, if you don't even know what is the burden of tuberculosis in a community which has only earning say 2,000 rands a month, or someone who's earning 15,000 rands a month. Clearly, it will be shown that from data that you can extrapolate from my country, that people who are poorer or people who have lower weights or people who have malnutrition due to any other reason have higher rates of tuberculosis. But no one has studies this problem because our health systems don't, they try to sort of avoid the question of finding data specifically on basis of economic information of people. For example, indigenous communities, what is the burden of tuberculosis in India? The burden of tuberculosis among the tribals, as we call in Adivasis, as we call in India, are 1600 per 1 lakh population, per 100,000 population, whereas in the general community it is 300 per 100,000 population. More than 5 times tuberculosis happens among the indigenous communities. And effective health services are not there in large parts. So I would ask the question: is ECG machine available in our hospitals, in rural hospitals? We could not see the hospital in Bela today, but I wanted to see whether they have a ECG machine lying there in the clinic. If people have heart diseases, then ECG machine should be there. But if you come to Joburg, you might have ECG machines in each clinic. So who decides what should be the facilities be available in each of those places? Is there a refrigerator to keep drugs like insulin in every small location where human beings are staying, so that they can keep their drugs in cold condition? And no one collects data. How many snake bites kill the poorest people? How many? Do we have no information among the black communities in a particular area? Is the proportion of snake bites or of any other disease, is it more or less than other people? We don't want to collect data because it might disturb the people in power to make some, they would not be able to acknowledge it, I think. So even the sources of data that we look at an international level, there is data. This man Bill Gates is collecting data for a system called Global Burden of Disease, and they don't collect data, they just make estimates. And those estimates proved majorly wrong in COVID pandemic, but they are the ones who are the daddies of the data in the world, and we all have to listen to them. And they have a so-called I'm not finding that word, where they have sort of taken on board almost all our faculty members in our bigger medical colleges, as they have co-opted them into saying that yes, we are the ones who are collecting the data, and this is the data that even the Ministry of Health in South Africa may be using, which are only estimates. The data, they don't collect data on each person that we know. And the Lancet as a journal has been guilty of supporting Bill Gates and the global burden of disease data. Richard Horton himself has been doing this. I mean, even though he's a friend at some level, but WHO data is also similarly problems, and there is also a lot of other information systems are not there. I don't even know what are the information systems that are available in South Africa where they are able to collect data accurately in a granular way for all our population. So do we have data to say what is the proportion of problem in shack settlements? Illness burden, is anyone collecting it? If our people who are not accessing hospitals, does someone come home to collect data about whether they have diabetes or not, whether they have an injury or not, whether they have a disability or not? If that data is not there, then you don't even act on it. Sickle cell disease is a disease that happens in both Africa and in Asia, in my country. So if a disease is, which is a genetic disease, so it should be equally manifesting in all populations. Whether you are poor or you are not poor, it should be ideally manifesting in a similar way because it is a genetic disorder. But in in Kenya and Tanzania in 1970, if there were 1,000 children born, 250 would die by the age of 18. 1/4 of children would die by the age of 18. due to the disease. But if you were a person who was non-black and you got sickle cell disease, sickle cell anemia, the chances that you would be living at the age of 18 after being born would be close to 950. Only 50 people would die instead of 250. That was the difference in the outcomes for a genetic disorder. Obviously, it is due to the poor person getting poor health systems and therefore not getting the right care. So this is what I this is the second or maybe the third statement I am making. Is very clear. There is this mythology in medicine and in healthcare that people who stay in small places, people who are poor, have less health problems. They have smaller problems. They have running nose, flu, and some diarrhea or some skin lesions, but they don't get big illnesses. That is why our governments in both South Africa and India can decide that hospitals should be there in cities and health centers or clinics should be there in the villages or smaller places. It is almost saying that there are larger number of illnesses happening among the people in the cities. But if you know why people are making hospitals in cities and clinics or very poorly occupied clinics in smaller places, is because they want to sequester the resources. The rich people want to keep the resources for themselves, so that when they get a fracture or maybe a abdominal problem, then they can go to a hospital and get the best care, best drugs, best surgeries, and people who are in villages or in smaller places or in shack settlements, they can use the transport system if they can get it and come to our hospitals in a sense. So this is therefore and as a practitioner of healthcare among the poor, I would say that doctors and in fact facilities for the poor, because they have more illnesses and they have less resources to manage them, have to be of a higher quality and higher order than otherwise. Because you cannot hope even to control the same illnesses, because people have, the foot soldiers are missing. I will talk about this later. And health systems for the poor, the doctors who have to serve the poorest communities have to be of a higher quality but if you look at any of the planning in the health systems, where will the cardiologist and the neurologist sit? They would sit in the largest hospitals of Joburg, not in any of the provinces of provincial, small towns of the district or of the country. And who decides this? Have we been consulted for taking such decisions? I don't think so. This has been the question that and also people don't understand, the health systems don't want to discuss even the pattern of illnesses. Forget about the numbers of illnesses. For example, in India that I know, we have a type of diabetes. We also have a lot of diabetes where we have such weights, as I mentioned, 41 kilos, 49 kilos. In US, 95% of people who get diabetes are those who are obese. But in my own country, in my own state, in my province, 70% of people who get diabetes are those who are undernourished. So there is so much of sugar in their blood, but their body cannot use that sugar. So to become fat or become, so it's like they are in a sea of plenty, they are starving. But no one wants to study lean diabetes. None of my faculty colleagues in my medical college that I studied or I taught in, or among my colleagues otherwise, are interested in studying lean diabetes, because any research takes money. So no one wants to study that thing because it is not affecting the city people. In Delhi and Bombay, that are my largest cities in India, there is no lean diabetes. Diabetes happening among the undernourished people. Or no one wants to study why malaria happens in certain seasons in India. And finally, heart diseases. I've realized that the area that I work in, a lot of people have heart diseases also. But the heart disease they have is not of the one which causes heart attack type. It is of a different heart disease where your heart sort of expands due to poor nutrition. But no one wants to study that thing. My professors don't want to, professorial colleagues don't want to study this. And this is one of the reasons why injustice is being heaped on us. So actually, there is a knowledge hegemony. How we generate information, how we distribute that information. There is a hegemony of the people who decide, who are running our health systems, whether in the medical colleges, our administrators, or our academicians, and I would even say in this case our media. Is actually they don't question those theses, and therefore injustice can perpetuate, can persist. So actually this is the problem that I would say when you talk about equity and people who decide, no, oh, we must have a health system which is cost effective. I would say bullshit. First we should have an effective health system, then a cost effective health system. The problem is our economists seem to be ruling our decision about healthcare. I know the systems have to be cost effective, but there's a pecking order for which, and the reason is because people who make decisions about healthcare do not bear the consequences of those decisions, because there are two health systems that are running, and people who suffer don't have a voice. So, I would avoid this to say that. So, like in snake bites, there has been no research done in the last 50 years. Because it only affects the poorest and the furthest people from big cities. There are no roads that are being made in many places. There are no vehicles on those roads, and if there is a vehicle, then there is no driver on that for that available, because the driver, in our villages, what happens is between 10 p.m. at night and 5 a.m. in the morning, the entire communities are almost we call it must, or they are they are either sozzled, or they are they're not available. So if you want to find an ambulance at 4 a.m. in the morning, it's impossible to get in central India, even though it may be running in the daytime. It's very difficult to get. And snake bites in India bite almost exclusively. 90% of snake bites happen between 11 p.m. and 4 a.m. But I mean, that is because of the type of snakes that bite us are of that nature, which are poisonous ones. So, and what are the type of skill sets that a person in Bela or in the Tembisa hospital may be getting compared to the doctor who's sitting in, say, Cape Town, or in, how are people posted there? They would say, oh, we don't need a cardiologist, or we don't need a person who's very qualified, because he would or she would, want to become a faculty member in a medical college. But they will not go out. They would expect that people should come to them if at all they can, negotiate the health system's ladder. Supply chain for drugs. You often, you might have 500 types of drugs in a bigger hospital, but in a city hospital, in a rural hospital, in a village hospital, or a small town hospital, there may be 50 drugs only. And this problem, of whatever, because in an unequal world, there is this not only heaped on all this, what I have already mentioned about the knowledge hegemony and the fact that we have unequal systems, is that we have trivialized it even further. Okay, these are village people, these are poor people, okay, give them a health worker, a community health worker. We will keep our doctors for ourselves, give them a community health worker. And don't train them, but just give them a 10-day training or 5-day training and leave them to their devices. Give them 5 drugs, allow them to use 5 drugs like paracetamol or whatever, but we will keep the more important drugs for ourselves. So, whether you talk about diabetes, heart diseases, joint diseases, cancers, this is the problem, or whether, WHO, which is the transnational daddy of public health, is guilty of trivializing healthcare. Sickle cell disease is not counted as a major disease by them. Mental health problems are not counted as major NCDs by them. They don't count asthma as a major illness by them. For them, there are only 4 major illnesses: diabetes, heart disease of the coronary type, or hypertension, and 1 or 2 cancers. That's all. They don't want to consider other things, and this is perpetuates because the people who represent there on these boards have been co-opted by giving them vacations and conferences or whatever, And there is this long tail of various type of NCDs that we know, which no one wants to talk about. And in our areas, a lot of people are offered this new vaccine called for cancer cervix, but if one gets but screening programs will not be there for detecting those cancers and treating it early. But and all these things which are important for healthcare, for health, sorry. So safe water, safe air, roads, public transport, food, adequate good correct food, not only just any food, and not just bread and sugary drinks, but whether everyone can afford a fruit a day, whether there is someone has a homestead garden where one can make sanitation, banks, I would say, and spirit. How are we ready to really look for this to struggle and to form our organizations together and work on it? These are problems that I see which will affect whether we are going to get care or not. So most of my work in the last 25 years has been on trying to get equity back center stage, and justice therefore because of that. So there are various concepts which have been vying for importance when we decide about health programs. So I would say this is the order of priority that I would say. It should be first equity based, then efficiency comes. Efficiency of a program should not be trumping equity. It should be then cheap but unaffordable. Cost effectiveness even comes later, because just because country is investing less in health does not mean that we should have ineffective health programs and humanity of systems. When we realized in Tembisa, were a lot of people who did not want to go to public hospitals because they feel that they don't get the dignity that they deserve in health systems. Someone should be at least listening to them when they're complaining about their problem. Someone should be at least offering a chair to them. Or if someone who's a 65-year-old grandmother who's going to a hospital, a 30-year-old doctor should at least wish her and give her the dignity that an elder person would deserve. Or a woman who's in labor should get the privacy and the dignity that she deserves during a difficult and emotional process like childbirth. So efficiency or equity has a choice that we have to make, and I think we as people who are working for our communities should be thinking about equity first and efficiency much lower down. So our focus has been on primary health care in this thing, and I would suggest the same for when we take on health programs in our communities, because whether we provide it or someone else provides it, we have to monitor the health systems that we're going to get. So, and when I mean primary health care, I don't mean just primary level care. If an illness requires hospitalization, then that is also primary health care. Primary health care is not second-rate medicine or health care for the poor people. That is immoral medicine. And even protocols in healthcare should not be very straight-jacketed. I would just want to give an example. Leprosy is an illness that maybe none of you have heard or seen, but it is a common illness, at least in very poor communities. And India, in my area, leprosy is a big problem. The WHO, which I said is the daddy of public health, they say they did some stupid studies in 1980s to say that rifampicin is a slightly expensive drug, should be given as part of the treatment only once a month for people in Africa and Asia and Latin America. But if you get leprosy in US, then you get rifampicin every day. Are we different animals? That you can allow, WHO can allow such a nonsense to be perpetuated, and they have been able to co-opt many of our academic people sitting in bigger cities. But this question is not addressed. How can we have different systems, different levels, different different standards of care, different for the same illness? So my thesis is that public health is not fundamentally different from clinical medicine, because underpinning of equity is the biggest problem. And I must say, a lot of people make baseless assumptions when they plan public health system for communities like ours. Does anyone know the meaning of a word called GOBSAT? Good old boys sat around a table. This is how decisions are taken. 5 people will sit and say, oh yes, I think we should give this drug, and this is the thing. Almost always there are no women in that decision making. But even among the boys also, they're not even men, I think, in a sense. And but this is how most healthcare decisions have been taken in most countries and most communities. And people will give problems. Oh, you are talking about a population of 5,000. I'm talking about an entire country. We can't have the same quality, same standards of care for the entire community. And excuses are given for complexity. Oh, you don't understand the complexity of providing care for a larger population. And expense. We have this much money. Let's do whatever we can do with this money. This is the way arguments are made when trivialized health systems are offered to the poor. So I would say for you particularly, I have this, physicians and health workers can be of 3 different types. The first is my standard type of a doctor who's a good doctor, who looks at an illness, asks the right questions, makes a diagnosis of the problem, then decides what is the treatment, and then offers the treatment, and then teaches someone else to do such treatment. This is a type of doctor we require. Type 1 doctor. Type 2 doctor is who will say, oh, if in Tembisa settlement, if there are people who get, say, 5 people get diarrhea, 5 children get diarrhea, then they say, okay, I'll treat the diarrhea, but I will also look at why did the diarrhea happen. I will go and check the water source, whether there was some, stool, feces mixing with the water, drinking water, whether the municipality had, there was a leakage in the water supply, and then, or if a lot of children are malnourished or they're obese, then you look at what is the type of food they're getting, can we improve the food. That will be my type 2 doctor. My type 3 doctor is who's asks difficult political questions and settles it. Why don't we have drugs for everyone in our settlements? Why don't we have price control over our drugs? Why are drugs so expensive in the community? Why are people being displaced from area? Why are people not getting electricity and or refrigerators in their own systems? People who ask direct political questions would be my type 3 doctor. So just as a joke, I would say a lot of people have asked me, what type of doctor am I? Am I 1, 2, 3, whatever? And I've come here. So I call myself Doctor 2.5, which is trying to be go beyond 2, trying to be 3, but reaching 2.5 till now. I'm also a little scared about getting a bullet or something, but but I still aspire to be 3. So this point I've mentioned before. When doctors are asking this question, when I gave food to the hungry, this is Archbishop Camara in Brazil. When he was asked, he said they called him a saint. But when he asked why the hungry did not have food, they called him a communist. So I think if I would say this is my definition of being a communist, and I would proudly say this. And this is my 4th message that I've learned. Illnesses that I see now, or that any one of us who get into health work would see, we have to start seeing them as only a biological, a bodily embodiment of a manifestation of deprivation. There are hardly any illnesses that happen among people who are not deprived of one or the other things. It is not due to a lifestyle that I want to drink more. There is also sociology of drinking, of alcohol problem, of other so-called looked down upon lifestyles. Even I would say the problem that I saw a lot of women with with obesity yesterday and today. And I think that's because our food habits are not bad, are not good. But the reason is why our food habits not good, because probably the access to good quality food is not there for some people, or they don't have the wherewithal to organize a foods pattern for themselves due to their working conditions. So this structural violence that is perpetuated by our systems, where there is the fact that you don't get whether safe drinking or don't have public transport. I realize that in even in Joburg area, there's hardly any public transport system which is provided by the state. Isn't that important for healthcare? I mentioned in the determinants, yes, it is very important. It's not that I can spend 20 rupees, 20 rands on a taxi every time. Everyone may not have the money, and taxis may not take very sick people. Also, this is, or ambulances are not available when someone requires it, and you have to, depend upon your own resources to do this. Sorry. So, giving the poorly, the most remotely situated health centers, the most poorest program facilities and staff is a problem. So, even if there is, would we have 10 more minutes if I say? So I would say, I would just use example of tuberculosis. When I ask this question to young doctors, they will give me this definition. Tuberculosis is a infection, bacterial infection, that affects the lungs, which is in our chest, and how do you diagnose the illness? You do some sputum testing, or you do make an X-ray of the person, and then you treat it if the person comes to you by 4 drugs which are given for 6 months, and usually you would improve. That was the definition. If one had to mention in 50 words, what is the definition of tuberculosis? That shows the mindset of how you look at an illness, which is not a bodily embodiment of deprivation, but a medical sort of a biomedical diagnosis. Or I would say this is my definition. Tuberculosis would be better called as consumption, because it consumes the body. When you get tuberculosis, if you've looked at anyone with tuberculosis, it consumes the body. Is a disease that largely affects the young adults in our community and among the poorest communities, whose body defense systems have been affected due to either food deprivation or HIV or diabetes or other reasons. And it can be best managed by addressing the determinants like food supply, like treating HIV well, like looking at preventing diabetes to happen, and by having a person-centric approach, not by just health center-based approach. And undernourished communities, and you have to work on those things. Your mindset about the illness will determine what type of health system we will run, is what I am trying to sort of get here. So this is a person whom I saw 15 years ago. He was a man who came to me with 52 years old with tuberculosis, and from a very poor community. I could not save him. When he stood on my weighing scale, his weight was 28 kilos. 28 kilos at 52 years of age. And this is the type of picture that I see among tuberculosis patients that I see in my community. Or a family of 3, the father, son and the daughter, all having tuberculosis at the same time. And yet, our system don't provide, our health system don't provide additional food. They say you just take medicines, but no, food is what you have at home, have that. But no, who advises the government? Do they consult the community? No food is provided. And I would allege here that our academia, I'm talking about our medical colleges and our nursing colleges, have failed the people. I would even say the academia, even non-medical academia who are talking about healthcare, have failed the people by speaking up for them. So another example I would say, when you're getting good healthcare, the laboratories are usually associated with hospitals. Laboratories for blood testing, for urine testing, for stool, for X-ray. But can the lab not go to the people if people are not able to come to the lab? In a sense, I would say, if Muhammad cannot go to the mountain, can't the mountain come to Muhammad in this case? So we taught our people, we asked this question to ourselves in our program: is it possible to get for a person who's staying in a far off village where there is no road also going, can that person get a diagnosis for malaria, testing for malaria? This was a time when we did not have these rapid kits for malaria testing. In 24 hours, if they can get a report for malaria testing. So we taught our health workers. This is a picture of my health worker who's going to a village house with her medicines and testing. She goes to the family. She cleans the finger and takes a blood drop, and then she puts the blood on a glass slide and allows it to dry. We have taught her how to do it, and then she makes it to soap boxes. Wrapped the blood slides in forms. And these are taken by school children who are going to a main road school, because all high schools are not there in all the villages. They have to go to bigger villages, and these girls are taking the blood smears from different parts of the villages, and then buses which only go to main villages, big villages, would collect all these blood smears from different from patients into a common bus that goes to my hospital, where someone is standing outside, buses coming from different directions. They will pick up those blood smear boxes and report them in 2 hours time, and then these would be reports of this will go back with the buses which go back from villages to these from cities to the villages in the afternoon. And then these children are now going back from their home, from their schools to back their homes, and they would take these reports to give it to the health worker, who will decide what treatment to give now. And we have been running this for 20 years. It's just that ideas that you have to think about how you can make healthcare reach people. You have to use both technology and politics to get the right type of healthcare. So you have to make health outposts which reach the people, rather than just say that, oh, if you want to healthcare, please come to my hospital. And someone said a health center should be as far as where a pregnant woman with a 2-year-old child can walk down to. It should not be that you have to take a bus or a taxi or an ambulance, okay, for certain illnesses, but for minor illnesses and for common illnesses, one should be able to have a health center at that distance, 2 kilometers or 3 kilometers, where a woman can walk, who's pregnant or who's holding a child in her palm, in her lap. That should be the distance of the health center. And that's why I'm saying it should be a settlement based health center, rather than hoping that everyone should come to a hospital, city hospital. And you need mid-level workers. So I would say this hegemony of the doctors, they say that, oh, we will be the only ones who will prescribe drugs, we will be the only ones who will be looking after. This is nonsense. We have to break this thing. The South African government has the possibility of community health workers. I think we should add to that, and we should use the laws that are governed, that universal laws that govern, that free drugs of certain types should be available with the health worker, who should be using testing and also treating people. And this is something that requires training and support, which we should provide from our system that we can develop. And I would urge this strongly for reasons that I will mention now, why it should be done. And doctors are not going to go to remote places, I can assure you, or in deprived places. In our lifetime, I don't think this is going to happen. Maybe even in their lifetime, it's also not going to happen. One other example that I want to say is drug prices. This is a thing that we have been observing in the last 3 days, but I'm sure the group TAC had been working on this for HIV medicines, but now there are other issues. The drug prices are the major cause of healthcare prices. It's not the salary of the doctor. It is not the machine that you put up. It is the drug prices that are governing. You bring the prices of drugs down by procuring generic drugs, high quality generics. You can reduce the cost of healthcare and use that money that you save in so many other things, by making more centers, by making more drugs available. So, and purchasing drugs is one of the common, and this is what we try to provide by generics in our health system. And I think that should be done by a network of health centers. Can be pressurized the government of South Africa or the provincial government to procure together. when you pool procure drugs, you can negotiate far lower rates with the drug manufacturers than you can do when you expect each health center or hospital to procure it on their own. I would ask this question, I'm probably, throwing a lot of questions and suggestions, but is privatization a direction for public health in South Africa? I don't know what proportion of your healthcare is privatized, but in India, which is one of the champion of unequal healthcare, 80% of healthcare is provided by the private sector. 80%. That means most poor people also go to the private sector because we have destroyed the public system willfully. So for me, privatization is a direct outsourcing and private-public partnership. This buzzword that the World Bank gave us, where the public provides, the government provides, and the private people siphon off the money. And I've learned that South Africa allows private practice by public physicians, which is another way of saying that you are private-public partnership within a human being. It's the same person who has a conflict of interest because now there is a profit motive to earn money from the private sector, from the evening private clinics. Why will they provide care of the good quality in the public system when they are working in the morning? So public financing has to be there and public provisioning has to be there. No country in the world has delivered health for its people through a privatized healthcare model. No country, not even the richest country in the world. And certainly South Africa can't be called a rich country because of this inequality. Till all the people are rich, you can't call it as a rich country, and this is really an unequal country then. And privatization has many things. There's a private pharmaceutical industry, there is private insurance programs that run for healthcare, and also private medical education. All three are sources of impoverishment of people. We should oppose them, and I think looking at public systems providing highest quality of care. So what are the choices before a professional, and I would say among communities, when you're faced with such problems? And I would take 7 minutes to finish this bit. What are the choices before us? I would even remove the word professional, but I would say between communities. When we are faced in such an unjust and an unequal world, and a very depressing world at that, we could be against the community and say, this is the way it is going to continue. Or we could be passive. We say, okay, you do it. I'm not going to be the great change maker. Or we could be mentally active. We could do some desktop work and make organizations and make submissions, which is also important. Or you could be physically active and run programs finally. So this is a set of choices that one can make. So service work, which I said is type 1 or type 2 work, is something that can be done. Have a health worker in each settlement. Wherever there are human beings staying, for more than 300 people staying together, I think we should have a health worker. One could have a figure of 1 per 1,000 health people, but at least if you don't have even that population, that even at 300 population you should have a health worker, which would mean about 20 families or 30 families, no? Oh, sorry, about 50 families or something. And you should have a health promotional plan, expecting that everyone, when they fall sick, then you will treat them is not the best way. If there is a lot of obesity that is happening, can we have a food plan? Can we have if people are not sleeping well and having mental health problems, can we have a health promotional plan so that those problems don't happen? I don't know whether in the Tembisa settlement is everyone doing 30 minutes physical activity as one of the decisions, or the people who are working in the forge, are they looking at having 30 minutes physical activity by which sweats enough? No, I know this is not being done, but but also to run an information system for people. What are the care that you can get in a hospital? What is the health? What are the drugs that are available in your local thing? What are the timings of the doctor to be there? What is the nurse? When do they visit the community? Those type of information systems could be run by us. and also for preventing problems like chronic diseases that I mentioned, including mental health problems. And this would actually be one of the finest ways to have a pragmatic solidarity with the marginalized. It serves the healthcare need for people, for problems that can be managed at that level of healthcare. But it also allows, whoever is providing care and the system providing together, to understand the politics of health. You cannot understand better except through examples like this, which theorizing will never allow. You understand, take many courses in political economy of health, it will not allow you to understand what is the real thing that is important. And I would say it's also one of the finest examples, or fine expression of ensuring, socialism and social justice, if you provide healthcare in whatever way after good training. And it's a good entry point for other types of, social justice work, whether it's for land rights, whether it is for wages, whether it is for housing, whether it is for other things. But if you ask for healthcare rights, then that is a good soft point for entering into more difficult and more suspicious, right movement that evokes suspicion from the powers that be. Advocating for health is the second bit of thing that I think communities like ours should do. Fighting for a basis of an individual problem is one thing, but fighting as a network, and if different settlements have health workers, I think that leads to a escalation of the spirit that I saw in the dance that we did just now outside, singing together. If individual people are singing, it is a different thing, but the peak that you can reach through that when you discuss everything together, when you network together, is something which cannot the brightest of individuals and the finest campaigns can never do, which networks can do. Against privatization of care, you should be saying someone was not getting glasses for reading glasses from the public system, because the doctors were writing prescriptions for glasses from outside. Why don't we, why can't 10 people go and shout at the health system and say we deserve our glasses. 50-year-old 50-year-old people go and say we all 10 need glasses from the hospital. Or campaigning for non-physician health workers. This is a longer fight. We know that we doctors are not going to go to areas that we want them to go to. Why don't we campaign for giving support, system support for non-physician health workers, which we might create or support in our own in our communities, or even studying things like impact of conflict on health, that no one seems to study. On pricing, can there be campaign? TAG can lead it again. Can all the essential drugs be price controlled in a country like South Africa? Like we have been leading this movement in India called All India Drug Action Network. Can TAG take TAG, or other the baby organization that it has fostered? Can it take it on? And healthcare in an unjust world is it poverty? We have to ask, and I would say, is it inequality? Is it injustice? I would say clearly it's injustice leading to inequality, and leading to based on poverty of that injustice causes. So this is this mythology that has to be broken, as I said, that you can provide healthcare for the poor by dumbing down the effectiveness of systems. Because we want to make an efficient system or a cost-effective system. So asking the right questions is another thing that I think we should do, besides advocacy and service provision that I talked about. What is the burden of disease that the poor suffer from? This question has to be asked. What is the healthcare package? What should be the drugs? What should be the sizes of the hospital that should be there at each level of health facility, which is catering to 2,000? Should every creche that the government allows, should it have a health worker? There are several technical questions we need to ask in illness care, but that we can we can include our if physician and healthcare colleagues, if we found them who can ask these questions also. Question about food and illnesses. What should be the right food that we should get, and how should we get it? Food is probably the best vaccine that we can think about, no? But how do you get the right type of food and the right quantity of food, quality of food? How do we? So if I ask the question, what will it take for every South African individual citizen to get one fruit a day? One fruit a day, which can save many things. Can we ask this question, and in a downstream way, look at what does it take to do this? Should we be only looking at people growing fruit trees in their own neighborhood, or there should be a public distribution system for fruits? Because this is perishable, then it has to be of a higher frequency of provision. Maybe every week or every something is there, or some way has to be found out if we are worried about preventive health care. But can communities at minor level, at smaller level, can they also think about how this question can be answered? Why don't we have price control? As I mentioned, we should about drugs is one thing. Should tertiary care, so should I support the dental care where someone is getting a dental implant in a city hospital by my wages in my small place? Should government be giving cash transfers for illnesses, or should it be giving providing the care actually? Can you monetize healthcare? I don't think so. So, and I would like to sort of end in the say that the battles against diseases, and will have to be fought and won and lost in the wide various expanse of rural areas or urban, shack settlements. They cannot be won. They cannot be fought and won or lost in medical colleges or in the in boardrooms or conferences, where the foot soldiers are absent. They are poorly equipped with ammunition. If I'm using the war lingo, but supplies and systems are poor. This is a picture from an Indian woman in central India, because most people and most poor people still stay in rural areas or urban slums in our world. And the burden of diseases and effects are disproportionately seen higher among them. So the question that we'll all have to ask is whether you want to do small work, or you want to do large work because there is more impact. But the work quality has to be good. It cannot be trivialized work for when you're looking at healthcare for the poor. And finally, I would like to end with this statement from Harry Potter, that it is in our choices of what work we do, how we do, that show what we truly are, more than our abilities. And I would rest my case here and ask you for any comments or questions that seem to emerge from what I have tried to. I'm sorry for taking on too many issues to be talked about here. Thank you for your attention.